Okay, thank you everybody for coming to this session. As you know, it's going to be recorded, so if anybody has a problem with that, please just let me know before we start. So we're going to talk about approach to first aid and management of wounds in horses, and I want this to be very interactive, so please ask questions as we go along and let me know if there's anything you don't understand. The learning outcomes for this session are firstly to be able to provide first aid for horses that have wounds, and to use your knowledge of anatomy to identify any deep structures that might be affected, such as bones, tendons, synovial structures, blood vessels, and to identify cases where you think that a deep structure might be affected and we need to do some further diagnostics. So first of all, what are the goals of wound management whenever we assess any case? We want to bring a horse back to its previous function, and we want the horse still to look good, have acceptable cosmesis, healing in the shortest amount of time so that we can get back to the normal function and the least cost possible. So we're going to work around this checklist, which I hope will be sort of a little template for whenever we see a case as an emergency in a hospital or outside in the field. I won't go through it now because we're going to go through it step by step. So step one, whenever we receive a case, obviously, is to take a history. So we need to check the horse's signalment, any comorbidities that the horse may have. Did the owner see the incident or not? Sometimes they tell you that the horse was kicked or that they hit a fence, but actually they don't know that, and sometimes that can be confusing. When did it happen and how? And has the owner given any treatment or first aid? Then we need to do a full physical exam. It's really easy to see a wound like this and get distracted and approach the wound straight away. So always try and just take a little step back at the beginning, see the horse walking, trotting, do a full TPR, and check for other injuries, because sometimes it might be that there's one massive wound that's actually not so serious, but there's also a septic joint, and that's going to be a much more difficult problem. So take a step back. If you've got some bleeding, then we can provide first aid with either a pressure bandage or a tourniquet to try and get the situation under control. Everybody seems to be more panicked when there's lots of bleeding, to try and stabilise the patient and keep the owners calm as well by trying to manage that. Vaccination is a particularly hot topic for us because most of our patients aren't vaccinated. So I would sort of say, if you absolutely know that the horse is vaccinated, then that's fine. But if you don't know, or if you're unsure, you can always use our tetanus antitoxin. And we're never going to go wrong, even if the horse is vaccinated, still using it. So it's always a good thing to do. Our initial medication, then we look at broad spectrum antibiotics before we've got a culture. So we usually go with Kangenta or TMPS, and then analgesia as well, NSAIDs, and there might be other things appropriate, like a nerve block. Then we're going to have a look at some of our additional tests. If we think there's going to be a lot of blood loss, we're checking for the PCV and trying to monitor that. And then if we think that there is some deep anatomy affected, then we're taking radiographs, ultrasounds, synoviocentesis. Then we're going to clean the wound, which sometimes is more difficult than it might seem. We always have to balance removing the debris and getting it clean with causing more trauma. So usually it's advisable to clip the wound, apply some sterile gel to stop the hair falling in it, then doing like a general scrub, and then a more specific lavage of the actual wound itself with some sterile saline. And then the big question, of course, is always to suture or not to suture, and there's many factors that influence that: the size of the wound, the location, how contaminated it is, and how much tissue loss we have. And then bandaging. We need to again look at the location, how much support we need, and also how much exudate, which will determine the size of the bandage, the amount of layers that we need, and whether we need some additional support as well. So also a brief run through of our little strategy, which we all know and we all use in the hospital all the time. So I just wanted to run through some cases now, using our little plan and see what you guys think about it. I saw in Malta. He's a 15-year-old standardbred gelding who was retired from racing and had a wound to the carcass. So this is what I was presented with. How are we going to approach? We know the history already, we know he's 15 years old, and we know that he has a wound to the carcass. What are we going to do next?
The case race?
Physical.
Yeah, physical. Yeah. Yeah, take x-rays.
Find out whether he needs any medication already.
Yeah. Yeah.
Try to make it clean. Do some x-rays.
Ultrasound. Yeah. So this is just a little like mind's eye view of what structures we're thinking about when we're looking at this. So what I was worried about the bones and the joints, but I was most worried about the extensor tendons. So if we think about where the level of the wound is here, it's exactly here. So this is like the dorsal view, the level of the skin off. So we've got the common distal extensor here and extensor carpi radialis here. And then also cross section, we've got our 3 joints there. So there's plenty of things to worry about. So here we are, Dr. Juan, here's your radiographs. What do you think?
Could we communicate with the joint? I guess.
Yeah, you can't really say either way, can you? From
It's
this?
very deep.
Yeah,
The bone.
for sure, that's very deep.
Yeah.
So how are we going to perform our synoviocentesis? Yeah, exactly. Because we don't want to go through the regular approach in the dorsal aspect because we might contaminate it. Okie dokie. So all's well, the joint's not septic. What should we do now?
Leave the wound around, leave the wound.
Ultrasound.
Yeah, so you couldn't see this earlier, but when you palpated the wound, you could see that the extensor tendon was involved. So we, sorry, this isn't the greatest ultrasound, but you can see there's more fluid in the sheath of the extensor carpi radialis, and that was obviously involved. So
So I have a question.
of course,
So when you do it, so okay, so you have a tendon rupture, you see it grossly, right?
Yeah.
But then your findings on your ultrasound, why would it have more fluid in the, if it's open, why would it have more fluid in the tendon sheath? Like, is it like the ventral aspect, like the distal aspect of it that fills up with stuff, or?
I guess so. This was like in the proximal aspect, there was more fluid in there. It's a good question actually. I'm not entirely sure what the answer is.
It's
Me neither.
inflamed, no?
Yeah.
It's inflamed and it's infected, maybe there is an infection inside.
But if it's open,
It still does. It does.
But there
Especially if it was proximal to the.
Like, I could put the scope in the sheath ultrasound guidance. There was like a lot of fluid there, but it's true. I just know I'll just fall out. I don't know. It's a very good question.
Actually, even though they're open, they don't normally inflame that easy.
No.
When the tendon sheath is open, it doesn't break.
No, it
It
doesn't.
stays there, actually it remains, the fluid
Yeah.
remains there.
the what, sorry?
Even
The
when they're
tendon sheath, even
open,
when it's open, it doesn't dry, the fluid stays there.
you think it would be
But it takes
really
time
easy
to, you know,
treat
for gravity maybe slowly, but it's not like you open a can of.
No. No, interesting. And so actually sort of cleaned our wound. Which suture pattern would we use? Go on, Dr. Anna.
I've seen a very similar wounds closed with single interrupted knee papania together with some knee papa, but they were even further above and below.
Okay. Yeah. So you basically just want something that's tension relieving. Those of you who've spent more time with me will know that I have a favourite tension relieving suture. So I of course did some mattresses with quills, but that's not wrong what you said either. There's plenty of ways you can do that. Yeah, so just to try and relieve the tension, and I put a drain in as well because there was quite a pocket distally. And how should you bandage a wound like this? We're going to have a lot of exudate because I've put a drain in there, and potentially we've got some deficit in extensor tendon function, and we want to minimise tension of the movement of the carpus as
Was
well.
the horse still able to walk?
Yeah.
Well, yeah.
Because the
You
collar
feel the
was
springs,
intact.
the dorsal spring.
Yes, I did this time. Yeah.
So here he is with his splints on. I didn't recover him in the splint because I was
So
worried
I was
about
gonna ask, how did you recover him? You can just recover him.
I recovered him with a normal bandage on, then I put the splints after. And yeah, he did well.
Good job.
This is another case, a little bit different. This is a horse, he was a thoroughbred that had escaped from his stable and was found a long way away, and nobody really knew what had happened. And he lived on a neighbouring island to where I was, so he just had a local vet see him initially, and that sutured the wound. But the wound broke down, so he presented to me a few days later with this wound in the axilla. So sort of working through our checklist, we obviously need to examine him. What additional tests do you think we should do for a wound like this? Culture? Yeah. Yeah.
We should check if it has any foreign body inside.
Yeah. I also scanned the chest because I was worried in case it runs further through.
Do you have any subcutaneous emphysema?
Yeah, but unfortunately his thorax wasn't involved, so that was good. So what would you do now? Yeah. 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 So we try to clean. This is like the beginning of cleaning the wound. There's some inflammation. There's some granulation tissue starting to heal a little bit. There's a lot of contamination.
I guess the horse was still an antibiotic.
Yeah. Yeah. So I thought we'd just do a little run through of the different wound classifications. So clean, it's maybe our surgical wounds. Clean contaminated is our elementary GI and urogenital, but still surgical wounds. Most traumatic wounds are contaminated, and this one I think is definitely infected. It's sometimes good to bear that in mind. So I went ahead, did some industrial cleaning, did some sewing like I like to do, thought I'd done a really nice job, and then the wound broke down again. As was right kind of predictable. So why do you think this wound broke down? What's like the most?
It was highly contaminated and it's
Also because it's area that you
Place where
can't
this-
immobilize them.
Yeah, exactly. So the combination of movement and contamination. Yeah. So the next plan, we have the secondary intention healing, and the owner was really did most of this themselves actually. They just kept the room really clean. Lots of Manuka honey supplies.
Sonotherapy.
Yeah, we didn't do any of it. Well, I didn't have that actually, but yeah, that would have been a nice option. Could have just ozone therapy.
And in this kind of wound that you can't place a bandage, do you don't place a stent and maybe can support, give some extra support to the incision?
Yeah, we could have done that, to be fair. That would have been helpful. What we actually did was we got him a bib, you know, one of the ones that goes like over the head, over the neck and the shoulders, and he lived in that just mainly to keep it clean and keep the flies off. It worked quite well. So then this is how it gradually healed and went away.
So what do you do with the flap of tissue? Do you just let it shrink?
Yeah.
Okay.
Yeah, because
Would you ever cut it off?
I very rarely cut anything off. So they're flat and became this eventually. Yeah, like it's a really good question actually, because in the initial phase sometimes there's like a rush to try and clean things up and you want to just cut things off, but I was always taught that if you have any skin you can use it as a physiological bandage, so I always try and keep everything that I can initially, and then sometimes later it becomes apparent, doesn't it, that we just can't keep something in, but usually I try and keep everything in the beginning. And it's a very topical one because we're dealing with a lot of eye lacerations at the moment. Yeah, this is a horse with a relatively simple eyelid laceration of half of the lower lid. So again, for eyes, to Dr. Marina's favourite subject, how do you approach this differently from other wounds on the limbs and in other locations?
This approach is different just because of the location, because of the anatomical structures
Yeah,
you have here.
exactly.
Normally they scratch more and everything, they're super annoyed.
Yeah, so just like when we look at a wound over a joint, we think, oh, what's going on with the joint underneath there? When we look at a wound in the eyelid, we think, what's going on with that eye? So, a little checklist again. So initially, I always find it quite handy just to block these horses because I just think it makes everything easier, so you can facilitate them with the auricular palpebral block. And then have a look at the eye, do some staining of the eye. Cleaning is obviously to avoid our usual scrubs and things, and just to use topical Zipline. And then the next point, do we suture or do we not suture? Yeah, we have to suture for sure. What sort of pattern might we go with for an eyelid? What's the special suture that we do?
I may use the 3-0, no? Normally use for this one.
Yeah, I like the 3-0 monocle. Or you can use any absorbed
It
or monocle.
depends on the extension, I think, depending on the depth of the wound.
Yeah.
First you have to try not to go through the conjunctival. I think it's a simple pattern first you start with.
Yeah.
And then the skin depending on the tension.
It's the egg shape, so you
That's
have
right.
to go do not is far away from working.
Yeah, exactly. So just like you said, so obviously avoiding the conjunctival so you don't traumatize the eye. But the figure of 8 suture is really nice because you can come across the margin and through the skin, but without actually going on the conjunctiva. And it just helps to really hold that edge in our position because it's so important to try and recreate the eyelid margin. Like what happens with this shape of the skin underneath, you can kind of deal with. But if we lose the congruity of the eyelid margin, then it causes us some drama. And then to protect the eye, obviously, with the fly mask after. And then my favourites, all my favourites. Oh, here's another slightly different one. This is a pony that was found bleeding from the mouth. So how might we investigate this? If you just presented with a horse, the owner's panicking, and there's blood coming from the mouth, that's all you know. Well, what might you do?
We check the mouth. We open the mouth. You don't do the physical exam.
Yeah, exactly. So we're just going to sedate, have a look in the mouth. Oh, we found this.
How did it happen, do you know?
Don't know. It's relatively common for horses to randomly do that in a stable, though. I've seen this quite a few times, and people have never known the inciting cause. Okay. It's bleeding quite a lot. How can we try and control the bleeding?
Pressure. Cold
Yeah.
water.
Yeah.
Adrenaline drug.
Adrenaline at the time.
Yeah. And we can try and do a tourniquet as well.
Oh, that's
With gauze. And that's quite useful because once you've got your gauze on, you can then also like get somebody to hold that gauze to pull the tongue forward, and then you can assess it better. So the patient obviously with our antibiotics, anti-inflammatories, tetanus, GA or standing. I would usually do these standing. Most horses are relatively tolerant to this. And again, just be careful when we clean the wounds that we use water or saline, not hemoscopy, or anything the horse shouldn't swallow. How are we going to repair this?
With first the positioning of the muscles and then the upper layer will be good.
Yeah. Can you remember the pattern?
That's the 8 shape I gave for the muscles. And knee, far.
Yeah. Yeah. Or far near far. Yeah. So we just want a big mattress basically again to reduce the tension. And it's really strong, so you probably want size 0 for something like this. So yeah, this wasn't my repair actually, but you can see we've got the big tension relieving sutures and then we've just closed into that position. And they have tongues here really well. So this horse was eating well in a few days later. And if the sutures are not absorbable, you can remove them in 2 weeks. And then we just have one last case. This was a horse that became a friend of mine that I got to know quite well. He presented from the races. He was disqualified in the races because he galloped during a trotting race. And then they realised that there was a wound on the fetlock. This wound here. So what are we going to do with this one? What structures are we worried about underneath there?
That looks like a suture.
The tendon should be cartilage.
Yeah, exactly. So we can skim through this a little bit. Because you know what's underneath there. Yeah, we could see there was quite a lot more fluid when we scanned the tendon sheath. One thing that I just thought it was nice to mention is the use of radiography. So this isn't actually the same case, but it's easy to do contrast radiography in the tendon sheath. And if we had done that in this case, we would have been able to see contrast leaking through the wound, which would have been a nice, useful other extra thing to do. In terms of the synoviocentesis, so the wound, I'll go back to the picture for me. The wound is here, so where would you take your fluid sample from? Which approach to the tendon sheath would you use?
Lower proximal.
Or distal.
Yeah, exactly. Yeah. It just shows, it's always good to know a few different ways. And this wound was septic, and we treated it in the usual way with tenoscopy and IOP. Yeah, very well. So, yeah, that's all my little cases that I have. Does anybody have any questions?
Very good. Thank you.
Oh.
Really like the slide.